So we're going to talk about diabetic ketoacidosis, hyperosmolar hyperglycemic syndrome, and lactic acidosis. First, diabetic ketoacidosis. The pathophysiology is quite interesting. Cells unable to use glucose feedback mechanisms kick in homeostasis to turn to keto acids as an alternative fuel. So the keto acids that are problematic for us are actually there for a purpose as an alternative fuel to glucose. And the counter-regulatory hormones that are driving this ketogenesis are glucagon, catecholamines, cortisol, and growth hormone. Precipitating factors for DKA, infection, stress, often noncompliance, particularly if you're in an urban environment, drugs, and endocrine disorders. Presentation, weakness, nausea and vomiting, tachycardia, and if intravascular volume depletion is significant, hypotension. Kussmaul breathing, classically described 150, 200 years ago. The very deep, rapid breathing seen with metabolic acidosis, and DKA was sort of the primary disorder that this was first identified in. Two things that can be potentially present without infection, the leukocytosis may or may not mean infection, and abdominal pain may not mean an abdominal source of infection and may go away as the DKA is treated. The pathophysiology linked to the clinical issues that produce morbidity and rarely mortality are the osmotic diuresis, that is literally purging the body of all the electrolytes and water, and the ketoacidosis that may be associated with profound acidosis. Diagnostic criteria for DKA, hyperglycemia, typically established at a 250 threshold, decreased pH, increased anion gap, and positive serum ketones. Notice that hyperglycemia is not always present, and decreased pH is not always present, and we'll talk about what circumstances will cause those to occur. First, euglycemic DKA may be seen when there is increased renal clearance of glucose, such as in pregnancy, in a fasting or low caloric state, in starvation, nausea and vomiting where the patient is continuing to administer insulin. Estimating free water deficit is a great board question. It's also very useful in clinical practice. What you're trying to do here, we know that in the great majority of patients with DKA, there is excessive free water above and beyond plasma concentrations of water and electrolytes. So there's additional free water lost with the osmotic diuresis that will need to be replaced. And we can calculate, get an idea of what that is with the knowledge that for every 100 rise in glucose, there is a 1.6 decrease in sodium, and that's the body's attempt to maintain extracellular osmolarity. And we can then back calculate to see what the sodium will be when we have corrected the glucose, and therefore get an idea of what our free water deficit is. You take the current serum sodium plus 1.6 for each 100 milligram glucose more than 100. So if someone had a 600 glucose, or let's say an 800 glucose, and you wanted to know what the sodium is going to be when you correct the glucose to 100. That's 7 times 1.6. Add that to the current sodium, and that may give you a value such as 150, for example, 155. 160, you begin to say, I need to start giving free water very early in my resuscitation. Let's do our first question. Which one of the following is not an acid? Beta-hydroxybutyrate, acetoacetate, acetone, or lactic acid? And remember, lactic acid's in milk, so think about that. And the great majority of people got the correct answer. Acetone, lactic acid is obviously an acid. We talk about that a lot in tissue hypoperfusion. Utilizing the anion gap and having an understanding of the ketone bodies, I've tried to give you this slide to sort this out. I'll go right first this morning. So beta-hydroxybutyrate is at the top of the metabolism. Beta-hydroxybutyrate is metabolized to acetoacetate and then to acetone. In DKA, you get a very high concentration of beta-hydroxybutyrate, and then as you treat the DKA, it's passed on to acetoacetate and eventually to acetone. When you get to acetone, it's no longer an acid, so the beta-hydroxybutyrate and the acetoacetate are what driving the acidosis. Now, of interest, when you have a bad DKA patient, they're going to have a very high concentration of beta-hydroxybutyrate, and as you treat it, you're going to shift that to acetoacetate and then eventually to acetone. We used to use the nitroprusside reaction in the laboratory to measure serum ketones, and that was a little bit problematic because, as you can see on this slide, the nitroprusside reaction that measures ketones measures acetoacetate and acetone, does not measure beta-hydroxybutyrate, and therefore it was possible to treat a severe DKA patient and see your ketones not go down, except that you were making significant progress in decreasing the anion gap and treating the ketoacidosis. The great majority of hospitals now have switched from serum ketones to direct measurement of beta-hydroxybutyrate, and therefore it no longer is a problem, and you can directly follow beta-hydroxybutyrate, which is a good marker of your progress with treating DKA. Utilizing the anion gap, the rationale for calculating the anion gap during the treatment of DKA is that it is a direct correlate with the ketoacidosis. As you treat the DKA, the anion gap decreases, and when you've cleared the DKA, the anion gap goes away. There also is a non-anion gap metabolic acidosis that develops with the normal saline resuscitation because that widens the strong ion gap. You're giving sodium chloride, which has a 154 sodium, 154 chloride. You're giving it to a patient that's got a much lower chloride than sodium. So when you pour a bunch of normal saline in that patient, it brings the chloride up and it narrows that gap between those two strong ions, and that increases the dissociation of water and you get more H+, and you develop a non-anion gap ketoacidosis. Let's do a little calculation here. A 28-year-old male with type 1 diabetes mellitus developed nausea and protracted vomiting. This continued for 2 days, during which time his usual insulin therapy was discontinued. I've shown you the electrolytes here and the arterial blood gases. We'll come back to the arterial blood gases, but the sodium is 146, potassium 3.3, 92 chloride and 24 bicarb. So if you look at this patient's electrolytes, you see a normal bicarb and you also see a normal pH. But if you calculate the anion gap in this patient, it is 30. So this is a nice example of why you have to calculate the anion gap in any patient that's acutely ill, regardless of what the bicarb is and regardless of what the pH is. So the delta gap here is 20, so you would have predicted with an anion gap that's 20 increased that the bicarb would have decreased 20, but it's 24. So the predicted bicarb would be 4, but the actual is 24. And therefore you have established the presence of a metabolic alkalosis that was present prior to developing the anion gap acidosis. How does that happen? It happens when someone has protracted and sustained nausea and vomiting, for example. So they get a big contraction alkalosis and then they develop DKA on top of it. Here's another calculation for you. This is a patient that had a sodium of 135 and the chloride plus the bicarb in this patient was 118. So this was an anion gap of 17, a delta gap of 7, an increase in anion gap of 7. The predicted bicarb was 17, but the actual bicarb was considerably lower, 8. So here you use that delta gap to calculate a bicarb that was higher than what was predicted. So that tells you that in addition to the anion gap acidosis, there is also present a non-anion gap acidosis. Mixed acid-base respiratory abnormalities. There are two ways to calculate what the compensation should be from a respiratory standpoint for metabolic acidosis. The easy one to remember is that you should be able to hyperventilate the PaCO2 down to reach the last two numbers of the pH. So if you have a pH of 7.20, you should be hyperventilating down to 20. The other is a PaCO2, the predicted PaCO2, what it should be is the serum bicarb times 1.5 plus 8 plus minus 2. That's the Winterbauer formula. You're unlikely to remember that, so you would have to have it written down. You can have either a respiratory acidosis or alkalosis that may coexist with DKA. If someone had pneumonia as the trigger for DKA and was hypoxemic, they might be hyperventilating down even further than what would be considered adequate respiratory compensation. Mixed acid-base abnormalities, we've already talked about these, alkalemic DKA and the post-resuscitation non-anion gap acidosis. You could always argue, why aren't we using lactated ringers instead of normal saline? And the answer is you could. There's no reason that lactated ringers wouldn't be equally appropriate as normal saline. I guess the reason we've really not switched over in this circumstance is that no one has ever linked that non-anion gap metabolic acidosis to any additional morbidity. It usually clears over about 24 hours or so. You certainly, for board purposes and real life, need to be able to calculate serum osmolarity, 2 times the sodium plus the glucose divided by 18 plus BUN divided by 2.8 plus ethanol divided by 4.6 and other things. There's also a formula that allows you to integrate those into the calculated serum osmolarity. This is important for a couple of reasons. It's not important as much anymore to actually know what the osmolarity is because we directly measure it. But it's important to be able to see what the osmolar gap is if you're looking for things that aren't normally present in the body that would drive increased osmolarity, such as volatiles, volatile alcohols. It's also important, and why I'm covering it in this talk, to understand something called effective serum osmolarity, which is extracellular osmolarity as it influences cerebral water content and cerebral function. For example, we're going to talk about HHS a little bit later. You have a patient with altered mental status and a very high glucose, and you're thinking, do I need to look for another reason for the altered mental status? Do I need to do a spinal tap? Or can I just assume it's due to the very high glucose and I'm going to treat it and they're going to wake up? So that formula, you don't use the BUN. If you want to calculate the serum osmolarity that could be driving altered mental status, you don't use the BUN. And the reason you don't use the BUN is because what produces the altered mental status is when you have increased osmolarity outside the brain cells, that you create the difference in osmolarity produces fluid shifts in and out of brain cells. And that's what's driving the osmolarity, driving the altered mental status. And urea is ubiquitous. Urea just goes throughout all the body, doesn't require any energy to move across cell walls. So urea is always present in equal concentrations inside and outside the cells. So when you want to know what the serum osmolarity is, it may be affecting mental function. You take the BUN out, and if it's above 320, 325, then I think it's okay to assume that it's driving the altered mental status. Fluid therapy for the average DKA patient. Typical patient is depleted 5 liters on average of isotonic saline, 500 to 1,000 mLs of crystalloid, initially normal saline, then add free water, half normal saline. So you want to give 500 to 1,000 mLs per hour, initially normal saline, then add free water. You could use lactated ringers. There's been a little bit of change of thought about insulin therapy. Most of us were taught 0.1 unit per kilogram bolus, then 0.1 unit per kilogram per hour, or 0.14 unit per kilogram per hour. This is relatively new, the fact that you can go without a bolus and use a little higher initial drip rate. In elderly individuals, lower dosing, 0.05 units per kilogram bolus, 0.05 units per kilogram per hour drip, or initially a 0.07 unit per kilogram per hour. The reason elderly individuals get a lower dose is because insulin works primarily in skeletal muscle, and elderly people have decreased muscle mass and therefore should have a lower insulin infusion rate. Insulin therapy, glucose 250 to 300. When it gets there, begin glucose infusion, 5 to 20 grams per hour. Typically switch into D5. Remember that insulin therapy is to correct ketoacidosis, and that glucose often needs to be supplemented to keep the glucose up while you are treating the DKA. The most common error that's made in treating DKA is to start titrating the insulin to the glucose. You don't want to do that. You want to titrate the insulin to the ketoacidosis. When the venous pH is above 7.25, you probably should have the insulin infusion rate that you have initially used, and then when the beta-hydroxybutyrate is negative in the blood or the anion gap is cleared, then discontinue the insulin. And this may require giving a couple of amps of D50 if you've still got a profound ketoacidosis and you're looking at a glucose that's already dropped to 100, then just bolus a couple amps of D50 and start glucose IV. What about stopping the insulin infusion? The only time you should stop the insulin infusion other than clearing the diabetic ketoacidosis is if you have symptomatic hypoglycemia. Otherwise, it should be when the anion gap is normalized or negative blood ketoacids. Remember to continue the IV insulin for 2 hours after the first dose of subcutaneous insulin because it'll take that long for it to kick in. Potassium replacement in DKA is very important. It's a major morbidity producer. You get fooled because in the presence of a significant acidemia, despite the fact that the body is massively total body potassium depleted, you may be looking at a normal or even an elevated potassium. And when you start giving aggressive fluid resuscitation and insulin, that potassium will drop like a rock. So you should start potassium as soon as the potassium is normal or is expected to be normal. Bicarbonate therapy, the concerns with bicarbonate therapy is that it may produce paradoxical lowering of intracellular pH. I'm going to cover that at the very end of this talk when we are talking about lactic acidosis. It also may produce a shift in the oxygen dissociation curve to the right, making it more difficult to offload oxygen in the peripheral tissues in these critically ill patients. Sodium overload, and the big concern with bicarbonate therapy is another precipitating factor for hypokalemia. Having said that, you should consider bicarbonate therapy when the pH is less than 6.9, and in that circumstance, a dose of 100 millimoles over 2 hours, 2 amps would be appropriate. What about phosphorus? Replacement is unlikely needed, despite the fact that you will notice that a lot of these patients will be hypophosphatemic or have a decreased phosphorus. We routinely do not target that particular deficit. However, you certainly could by giving potassium phosphate instead of potassium chloride. Monitoring glucose by ChemStrip every 1 to 2 hours initially. Potassium, very important, as I keep mentioning, every 1 to 2 hours. Chemistries every 4 hours for the first 24 hours. We don't do arterial blood gases much more in patients with DKA because we have found that venous blood gases do the job in most cases. In patients that do not have tissue hypoperfusion, non-shock patients, the arterial PCO2, the venous PCO2 is very close to that value, and the pHs are also very close. So there's not much difference, and certainly not so much difference that it would make a big difference for why we want to use it, which is to track and monitor how we're moving pH and just to make sure our PaCO2 is adequately compensating. This is not in my territory, but it's important for boards and for real life. I think we're going to see in our shock patients, I'm beginning to see a return to looking at the arterial venous CO2 difference. When you have tissue hypoperfusion and shock, you circulate the blood through the lungs and we pull the normal amount of CO2 out. So you maintain a CO2 that's either normal or usually decreased in the arterial blood in compensation for shock, acidosis. But with the tissue hypoperfusion, you have trouble getting the CO2 out. So the venous CO2 tends to go up, the arterial PCO2 is lower, and you can monitor the severity of your tissue hypoperfusion with the arterial venous CO2 gradient. Urine ketones, what do you need to know about urine ketones? If the urine ketones are negative, DKA is not present. However, positive urine ketones are not useful because it does not make the diagnosis of ketoacidosis. So in the ED, for example, it's a useful screening tool to say that the patient does not have DKA. Let's move on now to hyperglycemic, hyperosmolar state, HHS, and let's look at a question. Which of the following is not true concerning the difference between DKA and HHS? Glucose is higher in HHS, the serum osmolarity is higher in HHS, pH is higher in HHS, and potassium is higher in HHS. One of those is not true. The right answer is indeed 4. Glucose is much higher in HHS. That's sort of its primary banner. And therefore, the serum osmolarity is higher in HHS. And there is less ketoacidosis in HHS. It's often very mild. Because of the high glucose and the osmolar state, however, being higher, you get a much bigger osmotic diuresis, so the potassium is a lot lower. HHS seen more likely in undiagnosed type 2 diabetes versus insulin-dependent diabetes. These patients have enough insulin to prevent lipolysis but not gluconeogenesis, tend to be older, often nursing home residents, and present with high osmolarities and alteration in consciousness. Typical presenting laboratory findings, higher glucose, typically equal to or greater than 600, higher serum osmolarity, equal to or greater than 320, higher glucose greater than 600, higher osmolarity greater than 320. Bicarb is almost always not profoundly decreased, mild ketonemia, and a very low serum potassium. Prognosis in HHS is determined by the underlying predisposing conditions instead of the ketoacidosis, and mortality is higher than DKA. Treatment, a lot of volume. In fact, the recommendation by most, including me, is that if you have a patient that's got pretty classic HHS, that you would start out initially with just fluid resuscitation until you get an idea of whether you're going to have problems with your potassium. And when you do start insulin, you always use the 0.05 dose. You use a lower insulin infusion rate. Let's move on now to lactic acidosis. This is what we dreaded in medical school, the Krebs cycle and anaerobic glycolysis and aerobic metabolism, and how we generate ATP to stay alive, and when the cells don't have enough oxygen, they turn to anaerobic glycolysis to create energy, and that drives the production of lactic acid from pyruvic acid. I think that looks like about 1843. Yeah, 1843. This is a German text. Described a 23-year-old female with puerperal septic shock, likely strep pyogenes, in which the chemical analysis of the blood directly from the heart revealed lactate. So lactic acidosis and the ominous sign of lactic acidosis we've known about for a long time. Lactic acidosis type A, this is the one associated with tissue hypoperfusion, the anaerobic glycolysis. It's been known, this is a very strong prognostic predictor. The higher the lactate in patients with shock, the worse the outcome. Also, what the lactate does over time with therapy is also a very strong predictor of outcome. Lactate equal to or greater than 4, entry criteria for early goal-directed therapy. We now know that you don't have to use the traditional early goal-directed therapy targets for resuscitation of septic shock. You can use them. They perform just as well as alternative approaches. However, we can't totally forget about that category of patients with the lactate equal to or greater than 4 because the Center for Medicare and Medicaid Services, CMS, is mandating reporting of sepsis process measures, how we treat patients with severe sepsis and septic shock. And they have also targeted the group with the lactate of 4 or greater for certain quality measures that would be tied to those patients. Point of care lactate has become very popular in the emergency department and in ICUs where we can use a bedside device to quickly find out what our lactate is and use it for resuscitation. Point of care lactate analyzers are now accurate. Similar values regardless of the type of blood you use, whether you draw it from a vein, whether you take it from a prick from a capillary, or whether you use an arterial specimen. You can also use a tourniquet for a vein draw without affecting the value. However, you need to remember that if you can't let the specimen stand for a long time if you're using a venous or arterial sample, if it's not refrigerated, because you will get in vitro glycolysis that will elevate your lactate. So if you're not going to run it immediately, it needs to be refrigerated or iced. There is a growing amount of data that using lactate clearance as a target for resuscitation of septic shock is useful, in which you target your tissue perfusion target of decreasing the lactate by 10%, 20%, or normalization of lactate to show that your therapy is successful. This was a study that compared lactate clearance with SCVO2 target and showed similar outcomes. This is a study that added looking at lactate clearance on top of looking at SCVO2 target, showing a better outcome in the group that targeted both. The Surviving Sepsis Campaign recommendation for lactate clearance in patients with elevated lactate levels resuscitate to a normalizing lactate. When I see these publications about 20% reduction in lactate, 10% reduction, when we did the guidelines, we thought about recommendation, and I think we all looked around the room and said if we had lactic acidosis due to tissue hypoperfusion, we would want our lactates normalized. Type B lactic acidosis, this occurs for reasons other than tissue hypoperfusion and tissue hypoxia. It's seen in congenital metabolic disorders. It's seen in hepatic disease because the liver clears lactate. So if you've got really severe liver disease, you may get lactic acidosis just through normal production. Seen in acute leukemia. seen with a lot of drugs. Some of the HIV drugs, it's seen with epinephrine, metformin, methanol, cyanide, ethanol, salicylate, ethylene glycol as a measurement artifact. Type A lactic acidosis, sign of tissue hypoxia, but is it a cosmetic issue only? And what I mean by that is the general opinion is that the lactic acidosis is not producing morbidity and mortality in the patients. It's just like thinking that when a DKA patient comes in and their pH is 7.1, are they suffering from that acidosis? Usually not. So unless they become incredibly acidemic, and the same thing here, the reason that there's a correlate between lactate and outcome isn't the lactate itself, it's the fact that it reflects the degree of tissue hypoxia and tissue hypoperfusion. This is a study that's worth commenting on despite being some time ago. This was a neat study. They took patients with shock and lactic acidosis, and they gave them the same amount, the same degree of volume resuscitation. So they got the same amount of osmolarity in the form of either sodium bicarb or normal saline. So it would produce the same amount of volume expansion in both groups, and only one group would get the decrease in pH. And you can see that they accomplished that quite easily. They took one group with the same amount of volume resuscitation to 7.36, and the other stayed at 7.23 because they got normal saline. And they had PA catheters in these patients, and you can see that similar effect on cardiac index. Same thing with vasopressors. So the general thought is that the acidemia that's present is not driving the hemodynamic instability. And that is where the recommendation comes that typically we don't worry about correcting pH in shock patients with bicarb unless it's less than 7.25 with appropriate respiratory compensation. And I'm going to finish with this point. I always finish this talk early, and I see Dr. Cruz was sitting in the audience, so I don't need to worry about that. I need this time for the PE talk. So we forget to correct this every year. So I'm going to use instead of the PE, I'm going to use an hour on it and 45 minutes on this talk. But let me finish with this point, because this is important. When we give bicarb as a buffer for acidosis, it works by combining with the H+ and producing carbonic acid, and then the carbonic. So you got all these H+ out in the tissue. And now you give bicarb, so the bicarb goes out into the tissues and it grabs the H+ and you create carbonic acid. That then dissociates to water and CO2. The CO2 has to then leave these hypoperfused tissues, come back to the heart, go through the lungs, get expired to complete the buffering process. In patients that have tissue hypoperfusion, it may be more difficult to drag that CO2 from the tissues back to the central circulation. So it may build up, and that gets back to what I talked about earlier, the arterial-venous CO2 difference, because when it is pulled out, you measure it, but a lot of it may not get pulled out. So you need to be careful about bolusing bicarb to patients with lactic acidosis, because you may end up getting a sudden sharp rise in CO2 in the peripheral tissues. That may diffuse intracellularly, and you get something called a paradoxical intracellular acidosis, and that's why it's recommended that if you do make a decision to give bicarb, that you give it by continuous infusion. and not by bolus. I've given you some references at the back that I read and I thought were really good for board review.